My name is Kelly Cox, and I'm the IMF Senior Director of Regional Community Workshops, and I want to personally welcome you. I've been with the IMF for 20 years now, and I have never seen the quality of programs that we're getting from our experienced professionals to this date. A whole bunch of new things happened just this past week, yet another possible treatment option for the patient. And this is a good program for the patient, family, or caregiver to watch. So I expect you to get your number 2 pencil and a legal pad out there, make sure the pencil's sharp, and to get ready to take a lot of notes. Now, I want to also thank our sponsors today, the Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, and Oncopeptide. I can't say that word, Oncopeptides. They have been very generous in helping sponsoring this program. Today's people, the doctors that will be speaking are on Myeloma 101 and Frontline Therapy will be Craig Cole, Breslin Cancer Center, Michigan State University. After that, we'll have a Q&A with the panelists. Then we get to hear about relapse therapy and clinical trials by Caitlin Costello, MD. She's at the Moores Cancer Center at UC San Diego Health. We'll have a question and answer panelist. And then how to manage symptoms and side effects by a dear friend of mine, Teresa Miceli. She has the most acronyms after her name than I've ever seen. She's with the Mayo Clinic College of Medicine, Rochester, Minnesota. Then we'll have a Q&A. As you can see, we are a family of speakers. As I said, my name's Kelly Cox. You're going to have Craig Cole, Caitlin Costello, and Teresa Miceli, and they're just fantastic speakers. Now, on the workshop details for today, 10 to 10:05, am I doing okay? I got 1 minute. 10:05 to 10:40, Myeloma 101 and Frontline Therapy with Dr. Craig Cole. Then we'll have questions and answers. And that leads me to my 5. I'd like to introduce Craig Cole. Dr. Cole, are you on right now?
Yes, I am.
Well, there you go. Let's start away here. Thank you.
And thank you, Kelly, and thank you to the IMF for inviting me back. Absolutely, I was telling Kelly earlier, just absolutely one of my favorite things to do is talking about myeloma, especially, my goodness, so many incredible things are happening in the field. And so I'm going to talk about, again, myeloma 101 and upfront therapy. We'll talk a bit about how common myeloma is, the spectrum of plasma cell cancers and disorders, a bit about the diagnosis, staging, and risk stratification. Then we'll talk about some of the science behind the treatments, the upfront therapeutic strategies, including induction, transplant, and maintenance, a bit about bone support, some of the new stuff. Then we'll reach into some of the really exciting clinical trials about upfront therapy for myeloma, and then some perspectives on the incredible things that are happening in the field. So some fast facts about myeloma. Second most common cancer, the most common being the lymphomas. 32,000 new cases were likely diagnosed last year, and there are 131 people estimated living with multiple myeloma in the United States at this time. It is frequently a disease of true adults. As I get older, I realize that 30-year-old people are still kids. So it's the median age being between 65 and 70s. And the incidence, there is a racial disparity, which we still are trying to understand between Caucasians and whites with Caucasians and blacks, with the disease being twice as more common in people of African descent than in Caucasians. Some of the common presenting signs and symptoms of myeloma: low blood counts, and especially anemia occurring in 60% of people, which causes a fatigue that can be really insidious over the course of months and months. Decreased kidney function. The kidneys filter out lots of chemicals and toxins from the body. So if the kidneys don't work well, people can have weakness and again fatigue. Those plasma cells can leave the bone marrow and go to the bone, causing softening and destruction of the bone, resulting in bone damage and fractures, and of course bone pain. Increased bone turnover, and again, myeloma does frequently leave the bone marrow space to go to the bone, and releasing calcium, and high levels of calcium in the blood can cause fatigue and weight loss. And we usually have an acronym for those signs and symptoms called CRAB, in the way of C for hypercalcemia, R for renal insufficiency, A for anemia, and B for bone disease. However, about 10 to 20% of patients with myeloma may not have any symptoms at all. So all myeloma begins at MGUS, where there are very few of the mutated plasma cells in the body. The protein that we'll talk about in a bit is usually very low, and the number of these abnormal plasma cells in the bone marrow is also very low. The normal number of plasma cells is 1%. And so your typical MGUS patient will have maybe 3 to 5% plasma cells in the bone marrow. And of course, with MGUS, the early precursor disease, there are no symptoms. And the risk of turning into myeloma is actually very low at 1% per year. If the number of plasma cells begins to expand, the protein goes up. So the monoclonal protein is over 3 in many cases, and the number of plasma cells in the bone marrow likewise goes up. But again, there are no signs and symptoms, those CRAB symptoms that we had mentioned. And then the risk of having symptomatic myeloma goes up in the order of 10% per year. High-risk smoldering is really an evolving field, and is, again, when there are no signs or symptoms, the CRAB symptoms, but the protein keeps going up and up and up in rapid succession, where it looks like then it is inevitable that a patient may develop symptomatic myeloma. And then the risk begins to really climb, where the risk is about 50% in 2 years. And then true multiple myeloma is, again, when there is a biopsy of those malignant plasma cells, either in a plasmacytoma or in the bone, or in a bone plasmacytoma, and patients have symptoms. Recently, in 2014, the slim CRAB features, or the slim high-risk features, were discovered and characterized. So when patients have plasma cells in the bone marrow greater than 60%, when their light chains are greater than 100, or they have more than one lesion on a sensitive test like an MRI, then the likelihood of them developing myeloma in 2 years is more in the order of 70 to 90%. And for those patients we usually treat, given how imminent it is for them to have a symptomatic disease. So for MGUS, smoldering, and even high-risk smoldering, we recommend clinical trials and close observation. And of course, when patients have multiple myeloma, either diagnosed through slim CRAB or through the classic CRAB symptoms, then we recommend clinical trials and treatment. So I mentioned labs as a way that we diagnose and we follow multiple myeloma. The important tests that we check on at diagnosis and on a regular basis include the CBC, which tells us how many red blood cells, white blood cells, and platelets are in the bloodstream. All 3 of those cells are made by the bone marrow. And the myeloma cells can crowd those normal cells out. The comprehensive panel tells us about the calcium, the kidney function, the liver function, and the bone status. And there are 2 tests that we use primarily for staging. So most patients only receive these tests a few times during their course. The beta-2 microglobulin, which is a protein that is a little hair protein that are on plasma cells, shed off into the serum and cleared by the kidneys. So the higher the beta-2 microglobulin, the more plasma cells there are, or the more the kidney function is decreased possibly by myeloma. And the LDH is a chemical that's released from cancer cells when they're dividing rapidly or when there are a lot of cancer cells. And so the LDH tells us the proliferative amount of myeloma cells or the total amount of myeloma cells. The tests that we use at diagnosis and to follow the disease are an assessment of the proteins, the monoclonal protein produced by the myeloma cells. The serum protein electrophoresis, or the SPEP, is a test that tells us how much M protein is being produced by the plasma cells. The immunofixation tells us what type. Either IgG, IgA, and in some cases IgD or IgE, and we'll talk about that in a bit. The serum, the plasma cells, the myeloma cells, can sometimes be mutated enough where they only produce light chains. So they don't produce that normal immunoglobulin, but only produce light chains. And for that, we either test using a free light chain test in the serum or the urine test, the 24-hour urine, for the detection of the Bence-Jones protein. So the SPEP, again, tells us how much myeloma cells there are. And what the SPEP does, serum protein electrophoresis, is breaks down the blood plasma into its components. Here's a graph of those blood components with albumin, the main protein in the bloodstream, followed by alpha, beta, and gamma. And then the gamma region is where the antibodies hang out, because antibodies are really heavy, and they sort out in that last region on the protein electrophoresis. And there's lots of different types of antibodies, which is why the gamma region is so wide. However, if you have mutated plasma cells that only produce one monoclonal, one type of protein of identical molecular weight, then you get that church spire peak, where all those proteins line up at one spot on the graph. And you take the area under the curve of that graph, and it tells you what the monoclonal protein is, which is a correlate to how many plasma cells are in the bone marrow and in the body. So we don't want to do bone marrow biopsies every month to see if someone is responding to therapy, but a correlate to how many plasma cells there are the M protein. And with treatment, you can then see the myeloma cells then go down because the treatment works, and the correlate to that is that the M protein would go down. So you know when to celebrate that a therapy has worked. The other tests that we check, that some patients will only produce light chains, those free light chains, those little fragments of antibody. And normally our bodies produce very small amounts of light chains by normal plasma cells. And usually they produce equal amounts of the two light chains, kappa and lambda. However, and the ratio between those two is 1 to 1. However, if someone has a, let's say, kappa light chain myeloma, the kappa light chain will be very high and will suppress the lambda light chain very low. And now you have a ratio between the two that is tremendous, like a ratio of 1 to 100. And just like with the M protein, that when by treatment, what you'll do is reduce that kappa down so that it returns to its normal level, and without those malignant plasma cells, then the lambda will go back up. And it would be vice versa for a patient that would have lambda light chain multiple myeloma. So most patients, 80% of patients, will follow their myeloma via the SPEP, and the immunofixation tells you the type of protein. So the SPEP, most patients will have IgG kappa or IgG lambda or IgA kappa or lambda. Rarely people have IgM or IgD myeloma. About 20% of patients their myeloma will only produce light chains. That is either followed with the Bence-Jones protein or in the free light chain test. And those light chains can get caught in the kidneys, in the kidney filter, causing kidney damage. And then some patients rarely will produce no protein at all. We call those patients non-secretory multiple myeloma. The other tests that we do, besides the protein tests and lab tests, is you look for holes in the bones via conventional x-rays. We've been doing x-rays for 121 years now, and for myeloma, and we can see some of those lytic lesions. However, PET scan, and there's one of my patients that has some of those lytic lesions in the skull, which are kind of thinning of the bones where the myeloma cells have hijacked those osteoclasts, which cause bone resorption. An even better test, which is 85% more sensitive than the skeletal surveys, are PET scanning, where it will light up where the myeloma cells have increased metabolism and causing bone damage. The diagnosis is confirmed and is absolutely necessary to obtain a biopsy or bone marrow biopsy to determine if the number of plasma cells in the bone marrow is over 10%, and especially to know the mutations which are driving the myeloma. So when we do a bone marrow biopsy, one of the tests that we'll do, besides counting the plasma cells, is looking at the different mutations that may have caused the genesis of the myeloma. So we look at those mutated plasma cells, and the best test that gives us the most information is the FISH cytogenetics test, and it looks for specific mutations that we know are associated with myeloma, because the conventional cytogenetics don't work very well, and we're still working on where gene expression profiling and next generation sequencing actually fits into myeloma treatment decisions. So the main tests that we check for mutations in myeloma are the FISH testing. And patients can then be divided into two groups. One is standard risk, which standard risk patients are a bit easier to treat and have longer responses to therapy. And those are patients that have on their FISH cytogenetics will have more than one pair of chromosomes, so 3 chromosomes, hyperdiploid, or translocation 1114 or translocation 614, or even normal cytogenetics, where the FISH testing doesn't pick up on a specific cytogenetic abnormality. High-risk myeloma, which we're starting to treat a little bit differently than standard-risk myeloma, because high-risk myeloma patients will relapse, have shorter periods of remission after therapy, are those that have the deletion of chromosome 17, gain of chromosome 1, or translocation of 414, or mutations in the p53 gene. So I think it's very important to know in 2020 which risk is assigned to a particular patient's myeloma, because we are beginning to treat people differently based on their cytogenetic risk. And it is part of our staging system. So when we stage myeloma, stage 1 is when the beta-2 microglobulin is low, so there's not a lot of plasma cells, and the kidney function is normal. That the LDH, that chemical that's released when the cells are rapidly dividing, is normal, and then no risk cytogenetics. Stage 3 is when the beta-2 microglobulin protein is high, so there are lots of plasma cells, or the kidneys may be a little bit more damaged, or if the LDH or the high-risk cytogenetics. And stage 2 is when people is kind of the in-between if they don't fit into either category. So how do we treat multiple myeloma in 2020? Well, we definitely use science. We definitely use science to treat myeloma. We use the immunomodulatory drugs, thalidomide, Revlimid, and Pomalyst, that I'm sure you've heard of. We'll talk about that in a bit. We use the proteasome inhibitors, Velcade, Ninlaro, and Kyprolis. And then we have the antibodies, which has really, truly revolutionized myeloma therapy in just the past 5 years. And there's so many other drugs that are coming, that have come down the pipeline, been approved by the FDA. And we need to add cellular therapy, CAR T therapy, which was just approved just today for the treatment of multiple myeloma. So let's talk about those IMiDs, the Revlimid. So how do the IMiDs work? How do they work to control the myeloma? Well, it uses science. So it does, the Revlimid, Pomalyst, and thalidomide do inhibit DNA to a very small extent. But a bigger part of what they do is that they were originally designed to inhibit blood vessels, thinking that if you starve the blood vessels from the cancer cells, that the cancer cells would go away. However, it really is the inhibition of those cytokines that causes the myeloma cells to die. A big thing is that it inhibits the bone marrow, the myeloma cells from sticking to the bone marrow stromal cells. Myeloma cells cannot live without bone marrow stromal cells. It also starves them to death. The myeloma cells are dependent upon those growth cytokines like IL-6. Without that, they'll die. And then the incredible thing that Revlimid, Pomalyst, and thalidomide do is they activate the body's own T cells, cancer-hunting cells, to destroy the myeloma. An incredible drug. Started out with thalidomide in the 90s, which then led to lenalidomide and pomalidomide, derivatives of thalidomide, which has this increased its activity. Iberdomide is the newest in class and is actually in middle and almost late clinical trials. And just recently, CC 92480, a cerebon-3 ligase modulator, which has incredible activity in very early studies in myeloma. The proteasome inhibitors, how they work is that there are these little proteasome organelles inside every cell, but really in myeloma cell. And you know, myeloma cells are very dependent upon proteins. They produce lots of proteins, those light chains and those M proteins. They have all those adhesion proteins. And so when myeloma cells produce those proteins and they have lost their function, then what happens is that they go into the garbage disposal inside myeloma cells, and they get chewed up by the proteasome and then spit out of the myeloma cell. And myeloma cells are extraordinarily dependent upon the proteasome because they're turning over and making tons of protein. What if you could inhibit that proteasome? If you could put a cork in the exhaust pipe of the myeloma cell, or pour cement in the garbage disposal, then you actually utilize that one feature of myeloma cells, that protein-producing feature, against them. All those proteins build up inside the myeloma cell, and they pop. They die. They just detach from the bone marrow stromal cells, and they can't utilize all those cytokines. And there are 3 proteasome inhibitors. The first was Velcade that came out in 2003, followed by carfilzomib, an irreversible proteasome inhibitor. And then the oral version of Velcade and Laro came out in 2015, about 5 years ago. The antibodies are so exciting for myeloma, that myeloma cells have a specific set of proteins that are on their surface that really tell you what a myeloma cell actually is, including CD38, SLAM7, and because your body doesn't make antibodies against myeloma, those antibodies have been made in the laboratory. And the antibody against CD30 is daratumumab and isatuximab. The antibody against SLAM7 is elotuzumab. Blintanumab was recently approved against the BCMA protein, and CAR-T was just approved just today, which is also against BCMA. The way that these proteins work is, these antibodies work, is that when the antibody sticks to the myeloma cell, it calls in the immune system, which destroys those plasma cells. Those T cells come in when they see that attached antibody and go into hand-to-hand combat against the plasma cells. Complement is a protein that attaches to antibodies that bores holes inside the cells. And the antibody actually cross-links beneath the receptor, which then short-circuits the plasma cells and kill them. And when the antibodies attach to the myeloma cells, they're detached and thrown out of the bone marrow. And again, without being attached to the bone marrow stromal cells, myeloma cells can't live. So we have all these tools of the trade for frontline therapy. And the standard induction therapy that we use for myeloma is usually RVD. So how do we treat a newly diagnosed patient? Well, again, like I mentioned earlier, we do a bone marrow biopsy and divide them into, and if a patient is not a transplant candidate, we divide them into standard risk to high risk myeloma. And then we use primarily Revlimid, Velcade, dexamethasone, combination of those drugs that I had just mentioned. And at times, if a patient can't receive Velcade for some reason, that we can use Revdex, which has been approved by the FDA. Very, very, very good therapy for myeloma. And then what we usually do, or frequently do, is have patients on maintenance therapy after they have their induction therapy. For transplant candidates, and I would say the vast majority of my patients are transplant candidates, and age is not a discriminator for transplant, that if they're high risk of myeloma, these days, and I'll show you some of the evidence of why we start leaning towards a 4-drug induction therapy, such as Dara-RVD, adding the antibody on to the RVD backbone, and sometimes use carfilzomib as a 3-drug induction. For standard risk patients, we then do RVD for 4 cycles, followed by autologous stem cell transplant. And we strongly recommend transplant because what we want to do is drive the disease as low as we can. On that iceberg model, we want as least myeloma. We want to drive so we don't see any protein. When people are in very good partial responses where their M protein has gone down by 90%, or complete responses where there's no protein at all seen in the blood test. And even with that, as you can see by the little red line below that, there still could be plasma cells left. That's when we start using minimum residual disease testing. And we're still trying to see where does that fit in the care of the myeloma patient. But it tells us how deep we can get responses these days. And with treatment, we bring down, again, the myeloma cell. So what I like to tell patients is that when we talk about transplant, we use a 1-2 punch. That we use RVD as like a right-handed punch. We're punching the bad myeloma guy, and the myeloma is not anticipating that it's going to get hit with a left hook. And you deliver that transplant, that chemotherapy left hook, and it knocks the bad guy out. We know that because of a trial that was done in 2009, the IFM trial, where they got patients who were age 65, and that limit was set by European standards for how old they do stem cell transplant. Those patients are divided either into receiving RVD for 8 cycles or RVD followed by transplant, RVD consolidation, and everyone got relevant maintenance. The one caveat to this trial is that at the time, back in 2009, there weren't a lot of available therapies for relapsed myeloma, so 76% of patients got a transplant as their salvage therapy. And so there really isn't a transplant versus no transplant, but more of a transplant versus delayed transplant trial. But it gave us some really important information, because what it told us, when you compare RVD with delayed transplant to RVD with upfront transplant, yes, that transplant has a bit more toxicities than RVD alone. However, a lot of most of those toxicities happen while patients are in the hospital or as an immediate follow-up outpatient and are controlled. But the big thing is that the median time to relapse, how long does it take the disease to come back? Longer with having transplant because of those deeper responses. The overall survival was the same between the groups, and the reason is that most patients that relapsed with RVD alone then received transplant as salvage therapy. So we now know that really transplant can be delivered either later or upfront, but we prefer upfront. And the big thing, the big news, is that those very deep responses were achieved by adding the transplant. You're knocking the bad guy out with that left hook that they're not anticipating, that knocks them out for a longer period of time, deeper response, and more MRD negativity, going deeper on that iceberg model. And we're starting in the update to this that was just at the ASH meeting in December, told us that MRD was a strong, getting down that very low level was a strong predictor of progression-free survival and overall survival. So based on the longer time to relapse and the depth of response, that we recommend stem cell transplant. So what do you do after stem cell transplant? Well, the Stamina trial told us about that. That was one of the biggest trials, randomized trials in the United States for multiple myeloma. And everyone got RVD induction. Everyone on this trial got transplant, and they were broken into 3 groups. Either they went to consolidation So they got more cycles of RVD after a transplant. They either got a second transplant or they got Revlimid maintenance. Directly to Revlimid maintenance, and everyone ended up on Revlimid maintenance. And a really important part is that for standard risk patients, it didn't really matter if they got consolidation or a second transplant, or went straight to maintenance. Because going straight to maintenance is a lot easier than those other options. We just go straight to maintenance. There's a question if high-risk patients would benefit from 2 transplants, and I still think we need to look into that a bit more carefully. There have been excellent 4 randomized trials looking at should we do maintenance therapy for myeloma, and the answer to that is yes, that we need to do that. It helps keep the disease down longer. It actually deepens the responses, and which helps with progression-free survival definitely, and overall survival. The duration of maintenance is unknown, so we're looking into how long, and there's clinical trials looking at different regimens, different drugs for maintenance therapy. One thing that we got in a recent analysis from the Stamina trial is that part of the Stamina trial, patients were allowed to stop their Rev maintenance after 38 months. And so some patients elected to stop, some didn't. And on this curve, and when the high part of the curve is good news, the low part of the curve means that patients were relapsing. And those patients that stopped on lenalidomide started relapsing a bit earlier than the patients that continued Revlimid maintenance. So but because of all the great therapies we have when people relapse, there's no difference in overall survival, but an improvement in how long it took to get to a relapse was prolonged by continuing Rev maintenance. So we're still looking at how long do we continue Rev maintenance in patients. Definitely, because myeloma can cause weak bones, that bone support is critical. Using bone strengthening agents as permiginate Zometa to help fill in the holes that was caused by the disease. We have great therapies to get rid of myeloma, and permiginate and Zometa help to fill in and reconstitute the bone. Vitamin D and calcium, essential in that, and we definitely engage our orthopedic support colleagues, our orthopedic surgery, physical medicine colleagues, and medications in order to control pain until we get the disease under better control. So I'll briefly talk about some of the new stuff, and I think the new and exciting area in myeloma upfront therapy right now are the results from the Griffin trial. So the Griffin trial was a clinical trial done here in the United States where they randomized newly diagnosed patients between RVD, the standard RVD that I talked about earlier, versus RVD with the addition of daratumumab, the antibody against myeloma. So these patients had 4 cycles of RVD or RVD alone. Everybody went to transplant, and then they received a consolidation phase followed by maintenance, and the maintenance with either Revlimid or Revlimid alone. And so patients on this trial either received the absolute standard of care of RVD followed by transplant and RVD and Rev maintenance, or they received the addition of Dara to that. The impressive things about, and again, a lot of this is early data, but the impressive thing is the addition of daratumumab did have deeper responses that after consolidation, there were more patients in stringent complete responses than in the RVD. The response rates between the two, excellent, 99% response rates. When I was starting to do this, 30% rate. When I was a resident, 30% response rate was the median response rate in myeloma. Now we have 100% response rates. And with RVD, 91% response rate, but deeper responses with the addition of daratumumab. And this is kind of a complicated graph, but the black at the top is kind of what I would bring your eye to, that those are the patients that had the stringent CRs where they couldn't find any plasma cells in the bone marrow. And after consolidation and then on maintenance, those responses deeper. So people got better responses even when they were just on maintenance therapy, and better with daratumumab. And MRD negativity higher again with the addition of daratumumab. So response rates were, and depth of response were greater, and we still need much more data on the progression-free survival, but between the two, both progression-free survivals are very good at 2 years, but really the tail of the tape is what's going to happen in the next several years to tell us if it's going to be practice changing for all patients. Because high-risk myeloma, it's really important to get those deep responses with high-risk myeloma. That's why we're beginning to use Dara-RVD based on this early data to get those really deep responses for those patients. And there are a lot of trials that are looking at 4-drug induction therapies. And my best guess is that that will be the standard of care in the next few years, if not more, even more incredible things. So again, when I first started doing this, I don't want to tell you how long ago, the responses were like 35%. We thought we were doing fantastic. But over the years, we are now, the standard really is to have a 80 to 90% response rate. And the major responses, we're expecting high numbers these days. So it's important to know what your goals of therapy are. To know what you want out of your myeloma therapy. We also want to that's why it's important to know what your M protein is. Either your light chain or your heavy chain, know where you start and know where it's going, because you really want to know that depth of response. You need to know when to celebrate and go out for ice cream, or when to talk to your doctor about other treatment options. And so it's important to know your M protein, because the more plasma cells there are, the higher the protein. And with treatment, then you know that will go down. What is your myeloma risk? Because definitely we're looking at risk and stage very carefully, because there are more and more treatment options available. And always talk to your doctor about treatment options, either upfront or at relapse. Critical thing. Know your response. Know the side effects of when to expect it, and know who to call, know who's on your care team. And I would always recommend getting a second opinion. I receive a lot of second opinions. I send my patient to other myeloma doctors with second opinions, because it's good for patients. It's good to hear a different person talk about their disease. And it empowers patients. It empowers me to hear other people's perspective. And so always recommend obtaining a second opinion. And clinical trials, none of this would be possible without clinical trials. With the new biology in 3 and 4 drug regimens, now the response rates for newly diagnosed myeloma are really in the order of 90 to 100%. It's incredible. We now have 7 drugs because CAR T was approved today. So 7 drugs approved by the FDA and 4 new classes. I need to update this slide, obviously, because of the new news that came out today. And we use novel therapy. It's incredible. I mean, when I first started doing this, the median survival of myeloma was 2 to 3 years. And now we're pushing 10 years. And it just keeps getting better. In 2004, there were 50,000 people living with myeloma. Now there's 131,000. It's not because the incidence has gone up so high with myeloma. It is the incidence has actually not changed for myeloma since 2014. So where did that extra 50,000 people come from? It's because people aren't dying from myeloma like they used to because of these incredible new therapies. And myeloma is not curable yet, but is definitely survivable, and clinical trials and new drugs being approved like today is the answer to that. Thank you very much. And
a lot of information and good information. I think that a lot of people will benefit by that. So let's go into questions. We got a few. Do you see them, Dr. Cole?
Yeah. And so the first question I got was that I had mentioned at some point about green leafy vegetables and vitamin C on Velcade treatment days. And there is some information that flavonoids and vitamin C in the laboratory, so this is only in the laboratory, it hasn't been proven in people, but in the laboratory, that flavonoids that are found in beans and green leafy vegetables and may inhibit the anti-cancer effect of Velcade. That's only found in the lab. But what I tell my patients is on the day that they get the Velcade, on that day of the week, that I would just, I would avoid the green leafy vegetables. Eat them every other day because they're super good for you, super good for you. Very important to have a well-balanced diet, and nutrition is critical. But on that one day is when I ask my patients to maybe lay off of it. With the carfilzomib, which is an epoxy ketone, doesn't have that effect at all. Let's see some of the other questions. So one thing about neuropathy pain is that there are great new medications for neuropathy. One thing we've really been very cognizant of is that IV Velcade has a higher risk of neuropathy, and that and sub-Q Velcade is a lower risk. So we always use, try to always use sub-Q Velcade. There was a study that I'm surprised didn't get more press. That was at one of the American Society of Clinical Oncology meetings, where they had patients with chemotherapy-induced neuropathy, and they randomized them between doing just rubber band exercises, where they would just sit in a chair and pull a rubber band, versus, or a resistance band, versus doing a half-hour walk for 3 to 5 days out of the week. And the patients that walked, the control was the resistance band people. The people who walked, their neuropathy started to report improvements in neuropathy after 6 months. So the trick with is that it takes a while for it to get better, but patients begin to have less neuropathy. And so what we will frequently do is use some of the medications for neuropathy, such as the gabapentin to help with the neuropathy, and then we work. Make sure they go to physical therapy if they need it, to get involved with their physical medicine people to come up with some type of exercise program to get them mobilized again, because it not only has you feel better, but it can definitely help with the neuropathy. But it takes time. It takes time. It's a commitment. With the one feature is a question about the kappa-lambda ratio and the kappa-lambda. And the one little thing that I would mention about the kappa-lambda test is that with some of the free light chain testing, that if there's that the kappa protein is metabolized slower by the kidneys. And so if someone has any which means that it takes longer for kappa to be cleared by your bloodstream on this test, not so much in your body, but on this test with kidney renal insufficiency. And so people that have underlying renal insufficiency, their ratios may not completely normalize. Their kappa may always still be a bit high, not so much because of the disease, but because of really dynamics with the test. And that's when I frequently will use a 24-hour urine to confirm a complete response to someone that has a kappa light chain. The lambda light chain is really a very super good test. I'm just looking at some of the other questions. So should myeloma patients be off maintenance treatment while getting COVID vaccine? That's a really good, they're all good questions. That's a super good question. And so the guidelines from the National Comprehensive Cancer Network from ASH and ASCO is basically get the vaccination, the COVID vaccination when available. And it recommends it for everyone. And I think it was ASHA recommends it for caregivers also. It's a very good question of when should the timing of it. We definitely know that we should wait 3 months after transplant because transplant, really changes the immune system. And so we have to wait for that to reconstitute before giving the COVID vaccine. The big question is Rev maintenance. There's some recommendations. Some people have said, well, you should maybe lay off of the Rev maintenance for a couple weeks before and then get the vaccine. Some people have said it after. We really don't have a lot of information. I'm hoping that we'll have more information on some of the dynamics of the vaccine in May. I know that we have, there's studies that are going on looking at that. But I really tell my patients that it's really important to get the vaccine, that if we can hold the Rev maintenance, that if they've been on Rev maintenance for a long time, not a bad idea. But if they're just starting on Rev maintenance, I'd get the vaccine regardless. But it's more important to get the vaccine than some of the timing issues. Let's see, other questions.
Go up.
Craig,
do you know if there's a support group at University of Michigan? Is that it? For African Americans?
Can you say that again?
Support group at the University of Michigan for African Americans.
I am unaware of a support group for African Americans at the University of Michigan. There was a project when I was there. There was a men's African American breakfast club that was for general health problems, not for cancer, but just general health problems, and was educational. But there wasn't one at the University of Michigan now. There is, the fantastic myeloma support group in Ann Arbor.
Sure.
That is fantastic, but it is not exclusively for African Americans now.
Well, if anyone's from that area, stand by. I believe that we've got a lady that wants to start one in Detroit, and Craig, I'll fill you in on that. It's very exciting what she wants to do.
And some of the other questions, what does it mean if all three immunoglobulin levels fall below normal? The normal immunoglobulin levels are checked, are made by the normal plasma cells. The abnormal ones, so if you have an IgG myeloma, you'll make a lot of IgG protein. And those bad plasma cells, the IgG producing myeloma cells, will kill off the normal IgM and IgA. So you have something called immunoparesis. When patients have light chain myeloma, of course, the light chain won't show up in the immunoglobulins because they're too heavy. And so you can have pan suppression of all the immunoglobulins when patients have light chain myeloma, because those light chain cells will kill off the IgG, IgA, and IgM. When patients are therapy for myeloma, especially when they're getting steroids, but all the myeloma therapies will decrease the production of immunoglobulin by the normal plasma cells. And of course, they'll hit the myeloma cells too. So you can get a decrease of the immunoglobulins across the board with a therapy for myeloma. And after the therapy is over, after transplant is over and on maintenance, usually those immunoglobulin levels will reconstitute themselves. And I'm just looking through some of these. Can myeloma be detected on routine blood work? Yes, absolutely. And so, you can look for signs and symptoms of myeloma routine blood work, such as the anemia, the high calcium, and the kidney damage. There are two specific tests. There are screening tests for myeloma. One is that SPEP test, the serum protein electrophoresis. It will look for the monoclonal protein. The 80% of myeloma patients that will produce the heavy chain or the IgG, IgA, and rarely IgM, and the free light chain test. So the serum free light chain test. Those two tests will detect 98% of myeloma patients, or in many cases, MGUS and smoldering. And so those are two tests that can be used. And being diagnosed. One thing, my mom had increasing pain around her back and ribs leading to the diagnosis, wondering if this will subside when the myeloma numbers decrease. And that's a super good question. They're all super good, but the amazing thing is how fast these therapies work. And the response, initial response is usually within 6 weeks. And in getting rid of the myeloma cells is the starting of the healing process. So getting rid of the myeloma cells definitely begins the healing process. And then it takes time. Definitely the bisphosphonates, the Zometa, the Xgeva, the permethrinate helps to heal the bone. And the trick is to use, medications, physical therapy, physical medicine, or orthopedic colleagues to bridge the point until the pain is better. And so I had one of my patients with myeloma who was newly diagnosed and in intractable pain. And I told her that when we get the disease under control, which we can do, that the pain in time will get better. A year later, she is up walking around as normal as can be. But it took time. It took time for those bones to heal and get better. And the most important thing definitely is the control of the myeloma.
Craig, I have one more question for you.
Sure.
It says, at what point can we expect to see CAR T option as an option for patients in first relapse?
Yeah, that is, I don't know if you can see me smiling, but that is a super good question. I know that's being explored already, especially for our highest risk patients. The deletion 17 patients have shorter periods of remission, and so it's being used upfront. Those trials are underway, and it's being thought to maybe use CAR T as instead of stem cell transplant. That is the consolidation of therapy. And so again, it will of course take clinical trials to really, show that. But gosh, with it being approved today, it really is, that door has really swung open for those clinical trials to really speed up, get going, so we can find the answer to that. It's a super good question.
Fantastic question and answer there, everyone. We really appreciate it. That wakes you up, and hopefully everyone had a break. I ate a croissant, and someone keeps bringing these fattening foods to me. I'm going to blow up because I'm already a big guy. But nonetheless, we're on to the show here. I want to take time to introduce Caitlin Costello. I've worked with her many times down at UCSD, and she is phenomenal. She's going to go into release therapy and clinical trials. Thanks, everyone, for joining us. And Caitlin, take it away.
Thank you, Kelly. I am just so honored to be here today again with you. I think the last time we were together a couple of years ago, this is just something I always look forward to every year, and I'm just grateful for the opportunity. And and really enjoyed listening to Dr. Cole. He left really big shoes here and set the bar pretty high for me. So I hope that I will be able to teach you a little something just the same. So without further ado, we'll talk about relapse therapy, and no better day than today with this exciting news about the first BCMA CAR T cell therapy being approved for the treatment of relapsed refractory multiple myeloma. I saw several questions in the chat about CAR T, and I'll try and answer some of those as well so that I can make sure everyone is up to speed on the new exciting thing that literally just happened before we signed on today. So let's move forward here and say, gosh, if I had only known when I wrote this title last week that the future is now, it truly is now. I mean, we really have been anxiously kind of awaiting for some of these new drugs to come through, and today is the day. So I figure it's important to kind of lay the groundwork a bit when thinking about, treatment for relapsed refractory multiple myeloma. And there's lots to consider for you and for your doctor. Some of the things I think about when I'm trying to come up with a good kind of cocktail, if you will, or whatever it is that we need for patients if their myeloma has started to misbehave again. Some of the things that I think about and make sure to have conversations with my patients is think about, okay, what therapies are you on? What have you been on? How well did they work? How long did they work? What kind of side effects have you previously had? What are the logistical considerations in terms of, can you take a pill, or do you need to travel for work, or do you need to, do you have difficulties getting into the infusion center? Are IV medications okay? And multiple myeloma has been a bit of an embarrassment of riches, honestly, because there are just so many options available now for the treatment of multiple myeloma that sometimes it can feel a bit overwhelming in terms of thinking about what is the next best treatment for me. And if you're confused, it's confusing. There's just so many good things to do. So I hope today will help to clarify a little bit of what goes through your doctor's mind, at least when we're trying to come up with the next, newest, and greatest for you. But things that I want to make sure that you are armed with your questions when you go to your doctor's appointment in order to think about what questions that you should be asking. So let's talk a little bit about multiple myeloma and think about how the relapses happen. So, multiple myeloma, I really think of it as a marathon. I mean, we're in it for the long haul here, and our goal is that it is, well, exactly that, long. I'm going to give up on these headphones. I am not working well with them. Bear with me one second here. Kelly, you got me? Is that okay?
Perfect. Go ahead.
Hopefully everyone can hear me okay. I'm going to move forward about multiple myeloma in terms of the way that it comes and goes. Is that, as you can see over on this far side of this graph here, multiple myeloma when it first starts can oftentimes begin as an MGUS. So that's a monoclonal gammopathy of undetermined significance. So when you think about where someone first was diagnosed with myeloma, well, it didn't happen overnight. We know that there was something that was in the background that was been kind of percolating over time. What that time frame means, we don't really know, but let's say it didn't happen yesterday. It's probably been there for months, if not years, trying to develop. Once it finally rears its head and you get all the good therapies that Dr. Cole talked about, maybe with a transplant, we hopefully get you into remission so that someday it's going to come back. And when it comes back, that's what we're talking about. How do we deal with it? Because we want to make it go back into remission away. It's like whack-a-mole. Something comes up, you smack it right back down again. How can we make that next remission be as durable as possible? Because one of the concerns is that when myeloma recurs each time that it does, it may be that the remission times kind of get shorter and shorter. Maybe it's because the myeloma is becoming a little more aggressive. Maybe it's smartening up a little bit. Maybe it's trying to figure out how to say, oh, yes, I've seen that Revlimid before, or I've seen that Velcade before. Yeah, not going to work. It's kind of like antibiotic resistance, really just for a very simplistic comparison. that ultimately you can see with this kind of funny pictures here. If you think about, you have all these kind of purple cells as part of the myeloma. Well, that's just one part of the myeloma that maybe we can put to sleep with Revlimid, or we can put to sleep with a transplant. But maybe that means that the next time it comes back, some of these blue parts of the myeloma, or a part that had previously been kind of dormant or kind of laying quiet, maybe that starts coming to life, where ultimately you're getting these very resistant multiple myeloma clones that over time may end up being not as responsive to the treatment. And so again, as I mentioned, when you're thinking about relapse, the things that I'm thinking about when I see you is, okay, how much myeloma is there? When people relapse, they relapse differently. Patients sometimes can find that their myeloma comes back slowly. Maybe your M spike has been kind of trickling along at 0.1, and the next time you check it's 0.2, and the next time you check it's 0.3. And over the course of many months, and sometimes even longer, you may find this, what we call biochemical progression, where you see that there's just very slow incremental increase in the disease. That can be very different from someone whose myeloma goes from 0.1 to 1.0 to 1.5. So it's really important to recognize how quickly your myeloma is changing. That's that M spike that Dr. Cole was mentioning. This is critical. It's important to know that 80% of people have an M spike, but for you people out there that just have a kappa or a lambda, you most likely don't have an M spike, and that's okay. We'll watch your light chains just the same. So first I think about is, how quickly do I need to make a move? How quickly is the myeloma growing? How at risk are you for that myeloma causing a new bone problem, or causing new kidney failure, or causing worsening anemia? These are all the things that make me understand how long I can sit in my hands and how quickly I need to intervene. When I'm trying to think about, treatments of what I want to give to you, I'm going to look at your kidney function. I'm going to see if your kidneys are well. Can they tolerate medications that may be slightly harder on them? Or how is, Merdad, you mentioned your neuropathy. I have to be so careful not to give you a medication that's going to cause neuropathy. Or maybe I say that, heck, that Revlimid worked so well for so long for you at some point. Maybe we go to a similar drug like that and hope we get the same bang for our buck out of it. So there's lots of things that we consider when we're trying to come up with your next best treatment. And oh, that embarrassment of riches. I had to actually add on last week melflufen onto this list. And had I known today was definitely going to be the day, I would have added on CAR T. But look at this. I mean, I've been around long enough to see, at least half of these be approved at this point. And it's just such a wonderful luxury we have. The FDA has just been so good to us in terms of giving us options. We'll talk a little bit about how good those options are and when the right times are to use them. But as this has become a marathon, as Dr. Cole mentioned, that patients are living so much longer, this is the reason. If we can keep myeloma at bay, I usually say, let's kick the can down the road as long as we can until the next newest and greatest comes out that's maybe going to be that cure. I'm very hopeful that in my lifetime, we are going to see a cure. And it's because of things like CAR T getting approved today that that's a real possibility. So the best thing we have going for us is that we have options. So when we think about what our kind of most common treatment plan is we oftentimes say, all right, we need 2 or 3 drugs. Let's put them all together. Let's add dexamethasone to that bunch. So we ultimately are going to have, so many different cocktails that you're going to work your way through. But again, then the FDA is going to come up with the next new thing, and we're going to be able to say, all right, I got my next trick up my sleeve. So here we go. So treatment goals. So this is an important part of this. Think about your goals in terms of what it is that you want to accomplish when your myeloma comes back. It's different for everybody. Everyone has different goals. It may be that your goal is to carry on working and traveling when we used to do that, hopefully soon again, and you need to get on the plane and you need to get, somewhere. So you got to take your pills with you, or you're retired and you're planning to hop in that RV and explore the country. Well, it's hard to do that when you're connected to an IV every couple of weeks or every week, whatever that may be. So one thing to consider, there are other people that say, I will do whatever it takes to live as long as possible. There are various quality of life considerations that are possible here, is to say, I don't want to spend my time, whatever that may be, in an infusion center. Or I need to understand that my myeloma is kind of exploding before my eyes. Now's the time where we just need to stop, get going, get treatment in before any more damage is done. So really need to figure out how all of these different considerations kind of interplay and overlap so that we can find the best treatment for you. So how do we do that? So I know you all talked a lot about different blood work that is done at diagnosis and the way that we would monitor you throughout your treatment course before and during and after a transplant, if you do that. But much of what we do is monitoring. After you've had your treatment, and if you're still on treatment and we're observing you while you're taking your Revlimid maintenance, for example, depending on how patients do that, I do that at some interval between up to one, probably not any less often than every 3 months for patients who've been on Revlimid for a number of years for their maintenance. But the things that I follow is the CBC. So I want to make sure that your white blood cell count and your red blood cell count and your platelets are all behaving. Sometimes Revlimid can push those numbers down, but when myeloma relapses, you can become more anemic as well. The chemistry panel is a way for me to watch your kidneys and watch your liver function and make sure your electrolytes are all in the normal area as well. Calcium, remember that CRAB criteria we talk about? Well, calcium is that thing we need to kind of keep tabs on, because if we see that calcium level starting to inch its way up, that tells us that patients are potentially relapsing just the same. So you really want to get an understanding of just how much the myeloma is growing in your body, but also how is it affecting your body. So that is kind of routine blood work that we look at. But the myeloma panel is a separate blood test. So make sure you understand that, someone had asked about routine blood work. Your average blood test that your primary care doctor does for you before you were ever diagnosed does not include quantitative immunoglobulins and the M-spike test and the free light chains. Honestly, it was just until someone finally thought about that as being a possibility that they ordered those too. But now, once we know that you have it, that's the opportunity for us to kind of keep tabs on it, because you really want to trend it. You want to watch and make sure that it goes down the right way, that it stays down as we want it to, and that we're keeping tabs on it if we're trying to see that it's misbehaving. And when you're thinking about, 24-hour urines, I know Dr. Cole had mentioned it. I guess I do agree with him. There are times and place in order for me to understand, if your myeloma has grown to a point where it's affecting your kidneys. When protein levels start increasing in your urine, it tells me your kidneys aren't working as well. So there's a time and a place for checking 24-hour urines also. Now, remember, the hope at relapse is that we catch it before any damage is done. And that's why it's so critical to watch your M-spike. What my job is really to do as best as I can, prevent new bone problems from forming, or new calcium problems, or new anemia, whatever that may be. Sometimes it's hard to catch it. But when you are found to have relapse, when it's found their M-spike or your light chains are starting to rise, it's certainly an opportunity to reevaluate, kind of take a step back, and let's just kind of take a big full picture again in terms of thinking about where the myeloma may be misbehaving. Now, skeletal survey was that kind of old-fashioned way where we would take x-rays, like 28 of them, of every bone in your body, and the radiologist would turn their head sideways and squint at it a little bit and say, oh yeah, maybe I see a little something there. But I really would say that skeletal surveys are a way of the past now. It probably was good to find bone problems about 60% of the time, but I'm not okay with 60% of the time. I need more sensitive, more accurate pictures of your bones. So, at least here at UCSD, we offer whole body, low dose CT scans. We can do whole body MRIs. I love to do PET scans as well. Your insurance doesn't love me to do those. But it's a way for me to kind of look at your whole body and not only potentially see old lesions and how they've healed, but new lesions, if any, have developed. And then bone marrow biopsy, everyone's favorite. I know we just torture you so with these bone marrows, but it's important. it really does give us helpful information. It's a way for us to assess the clone. Has it changed at all? You probably talked about mutations beforehand. As the myeloma becomes more resistant and relapses, we can see that it changes and new mutations may occur. And what we hopefully will see is that those mutations will someday have a treatment that particularly fixes those mutations. Now, we do have it in one particular drug called venetoclax for patients who have a translocation of the 11th and the 14th chromosome. But that's the only one for the meantime. But we're very hopeful, like with many other cancers, that there are mutations that are going to be found that we have very specific targets or medications to fix. So all of these are the critical things that should be done at relapse. So we can really take a step back and take a new look at your myeloma and see how anything has affected your body or how the myeloma has changed. So we kind of mentioned this a little bit. So if you break it down into three kind of specific categories, these are the things worth thinking about. So let's think about your disease specifically. So when I'm thinking about your new therapy for you, I'm going to look at your disease, as I mentioned, and say, is it exploding before my eyes? Do I need to act fast? Because the faster it comes back, the faster we need to act before it causes any significant compromise. But as I mentioned, if it's a slow biochemical progression, maybe we can watch it for a little while and try and find the exact right minute to intervene. There is no M spike that I say we absolutely have to intervene at this point. I really look at the trends. Technically, there are criteria that say if your M spike increases an absolute value of 0.5 or 25%, that tells us that it meets criteria for progression. But I think it's important to understand the nature of the relapse. And as we mentioned, risk stratification, right? So if we do your bone marrow biopsy and we look to find if there's any high-risk chromosomal abnormalities, like particularly written there, deletion 17p, translocation of 4 and 14 or 14, 16, this kind of gives me some information to know if you have an aggressive myeloma, just how aggressive we need to be back. So it really helps me understand how pushy I need to be when it comes to choosing your next therapy. And also disease burden, how much of it is in your body, as we mentioned. If you have had several new bone lesions unfortunately develop or your kidneys have been specifically affected, we need to be more aggressive to slow that down and heal your body. But let's think about, if not disease related, therapy related. Well, let me think. Well, you had Revlimid and Velcade and dexamethasone, and then you had a transplant, and now Revlimid maintenance, and now it's back. Now what? Okay, well, the Revlimid clearly stopped working, so let's not choose Revlimid as part of our cocktail. Let's try and go to something else. And that's where you can go back to our list of medications that I showed previously and say, all right, these are our options. Sometimes it's important to think, well, we've just been on Revlimid, so let's switch drugs and let's go to a different class of drugs to see if that works better. And let's combine it with a medication that I've never seen before, because I'm trying to outwit this myeloma here. So everything we're trying to do is outsmart it. So if we think it's becoming smarter, then we have to stay ahead of it. Thinking about regimen-related toxicities. So as I mentioned before, if you've had very bad neuropathy related to prior Velcade use, I'm not going to be pretty excited about trying Velcade again. If you have any heart potential dysfunction or high blood pressure, or have had heart attacks or heart failure, things like that, I'm going to really think twice about whether Kyprolis or carfilzomib is an appropriate choice for you. If you had been on Velcade as maintenance for several years before things started inching back, maybe we could say that class of drugs, maybe that's an option for you. So I think there's lots of therapy-specific questions that we need to consider. And last, but often most importantly, is cost. Here we are telling you that you need to stay on medications for months, years, decades, whatever that may be. That really takes its toll. And thank goodness for all of those companies and philanthropic organizations that offer grants to patients to help cover the cost, because it's stupidly expensive how these Revlimid costs. It's just not fair. So I think, sadly, I have to say to patients when I'm thinking about what the side effects of treatment will be, but there's a side effect in your wallet as well. And unfortunately, we have to take that into consideration. And then lastly is patient related. So things I think about, what are your other medical problems? How do you have rides to get to the infusion center? Do you prefer an oral regimen? Do you prefer an injection? Do you have an insurance, do you have an infusion center nearby? Are you treated by a local oncologist, but you go see Dr. Cole in Michigan State and it's just too far and too cold there, so you don't want to go back there? There's so many different considerations to think about when you're trying to choose your next therapy. So as I mentioned, you can have that slowly progression, asymptomatic biochemical relapse where you see that on 2 consecutive M spike checks. You can see that your M spike is eking its way up. Maybe we can just watch for a little while, but watch pretty closely. If I've been watching you every 3 months, now you're getting watched once a month, so that I can catch it, so that things aren't changing faster before our eyes. Everyone's different. You may find the asymptomatic high-risk disease is starting to double, where the M spike, as I mentioned, goes from 0.5 to 1 to 2. And then there are those people who come back in and say, Doc, my back hurts or my leg hurts, or I fell and I have a new fracture, or whatever it is. And those are the people that we just have to start immediate therapy on. So strategies, there's different approaches, as I mentioned. We could go back to Old Faithful. If something worked well for you in the past, maybe it's something we want to think about recycling. So say you had RVD, Revlimid, Velcade, Dex, got a transplant, had been on Revlimid maintenance. Well, that Velcade worked really well. Maybe we could go with Velcade and we could combine it with some of these new agents. Lots of new agents. Now, remember that a lot of the novel agents have specific criteria outlined by the FDA during their approval that says you cannot use this unless you've had 3 other drugs before it, or 4 other drugs before it, or you've had all the other drugs and nothing else is left. So there are very specific criteria that we, in theory, are kind of held to. Salvage conventional chemotherapy. Gosh, one of the things I love about my job the most is when a new patient with myeloma comes in and says, Doc, am I going to lose my hair? And I say, no, not until the transplant. But at least with Revlimid and Velcade and Dex, like there are so many drugs that are available that don't cause kind of conventional chemotherapy side effects that you see in the movie of hair loss and nausea and vomiting. But there are people that have very aggressive myeloma that need the very aggressive treatment back. And so there are times when we think about saving our big gun in our back pocket and shooting that myeloma down as fast as possible. Stem cell transplant, remember, you did it up front. Many of us, when we take your stem cells out the first time, save another bit for a rainy day. So we can have them in the freezer. So if we decide that after 5 years, after your transplant, your myeloma came back, well, I got a couple more left in the freezer. Maybe this is a good option for us to think about using again. So certainly worthwhile talking to your doctor about that. And clinical trials, you all have all these medications available to you because of the super brave people that ahead of you decided that they wanted to participate in a clinical trial. And clinical trials have still that kind of concern about, am I a guinea pig? Am I getting a placebo? None of that is ethical, and none of that happens anymore. What I tell my patients is if for clinical trial, you are getting the standard of care, well, at least I should say this, I am going to enroll you on a clinical trial, that you are either going to get the standard of care, which I know works, or you're going to get the standard of care with something else in addition to see if that makes it better. So either way, you're getting the best of both worlds. You're getting what is normal, or you're getting potentially something that is better. So it's a win-win either way. So please always ask about clinical trials. There are so many good options out there that I would love to be able to give to my patients, but I can't write a prescription for it because it's not approved by the FDA. But if that's available at your cancer center, ask about it, because maybe you'd be eligible for a clinical trial. So let's kind of break them down a little bit. So when we think about relapse, we're going to do a combination of medications just like we did in the very beginning. So remember, you have your proteasome inhibitors, your bortezomib or Velcade, carfilzomib, Kyprolis, ixazomib, Ninlaro. That's one group of medications. Now, we don't combine 2 in the same group together. So what you're really trying to do is you're probably going to take one from each of these drug classes and combine them together. So whether you do 3 drugs together or do 4 drugs together, that is, kind of up for debate as we speak now. Let's say at a minimum, you're taking 2 drugs, 1 from each class, and combining it with Dex. So whether you have a triplet or a quadruplet, we need that as kind of a backbone together so that we can treat your relapsed myeloma. So things we've talked about is we know now that doing 3 drugs is better than 2 drugs. So we know that patients have better response rates, meaning it works better. We know that it stays away longer, which is all we're trying to do, is try and get people progression-free survival. Sorry for the acronyms. Longer progression-free survival is make it go away and make it stay away, right? So the most important thing we can do is that. And if we can make it stay away, then we kick the can down the road until the next newest and greatest comes around on March 27th, 2021 with a CAR T, So there is an importance of trying to get deep responses, because the deeper they are, which means the more successful the treatment is, the longer it's going to last. So most patients are eligible and should receive at least 3 medications together. So Dex being one of them plus 2 others. So and when you're thinking about it, daratumumab is just the gift that keeps on giving. I would tell you that this is a medication like every other one that was approved after you've had 3, 4, 5 plus prior lines of therapy. And we just realized how good it is, that it keeps just moving its way to the front. That's how all these drugs get approved. They start off for patients who have no other options, and then the studies keep going where they say, look, it works, it's effective. Why are we waiting? Why can't we do it sooner? And so now we can use medicines like daratumumab and combine it with our old faithful, our new old faithful, I guess I should say, lenalidomide, Revlimid, Velcade, Kyprolis, whatever it is. So it's a little bit of alphabet soup a bit, where you kind of just try different cocktails all around. And a lot of it is based on the decision-making we talked about previously. What has worked before? What hasn't worked? What drug have you not had before? And what side effects have you had from previous drugs that make me need to consider including or excluding one of your options? So a similar chart, I should say, I'll kind of push through this to say that at least historically, when you see our combinations, we can see that the combinations together, Dr. Cole showed a really nice Griffin data showing that patients who are newly diagnosed have 99% response rates. I mean, these drugs originally, pomalidomide, or carfilzomib, daratumumab, all by themselves have about a 20% likelihood of working. But when you start piling them together, they all add up, they accumulate. And so you can really get a sense that medications are complementary. They work well together. So using one by itself is really not the way to go. But at least that set the bar for us, so that now we're starting to look at some of these other approaches, the kind of immunotherapy approaches that we're going to touch on next, is a way that we can kind of have a bar that we know what we're trying to beat. So as it stands, when we're looking at kind of novel combinations, last year there was a handful of different cocktails that were approved. The one that I think has been absolutely the most impactful is the subcutaneous daratumumab. So we used to give this as an IV for 8 hours in the first day, and you'd hang out and stare at the ceiling and curse me for making you be there. And now let's just give you an injection over 3 minutes and get you the heck on out of there. So I think that has been kind of the biggest game changer that we've seen in the course of the last year. I really do like the Candor study, which was done in patients who had relapsed for their first time or second or third or fourth time, and said, if you hadn't had daratumumab, maybe now we use it and we can combine it with carfilzomib, and that is a nice combination of medications together so that we can try that to see if we can get a good bang for our buck. So the Icarius study, just as a quick mention, ISA is our little nickname for isatuximab, is a similar medication to daratumumab in the sense that they both work the same way by finding this little tag on the myeloma cell that says, hey, I'm myeloma cell, come get me. They work very similarly. So when you're thinking about how, we are in general are trying to approach this, my general comments on relapse refractory myeloma, if it's your first relapse or your second relapse or whatever it may be, I kind of like to think of it as a Peloton. And I have to give credit to my good friend, Dr. Nina Shah, who I stole this slide from because she is nothing short of comedian, to say is that at Peloton, everyone's doing it. The way of the future that is clear now is, and from the Griffin data and everything that's out there, is that CD38 is a very important target on multiple myeloma cells. So why wait? I really think that daratumumab should be given as soon as possible for our patients. And then it's just a matter of what do we combine it with. Combining with carfilzomib is extremely effective. But that certainly brings up the question, well, if I had daratumumab in the very beginning, what next? So yes, that's the kind of new frontier we're trying to figure out what to do. So a brief mention, and I know that people have very strong opinions on transplant, and big disclaimer, I am wildly biased because under my title, it will say I am a bone marrow transplanter. I believe in bone marrow transplant until someone tells me that there's something better that is going to allow people to live longer and stay in remission longer. So for the people who are worth considering a second transplant are those who did well with the first one, and did well meaning that it was successful. What's success? At least 2 years. The general guidelines recommend that you could consider a second transplant if the first one worked, meaning that got you down into remission or you had a response to it, and that it worked for at least 2 years. 18 months feels a little bit short for me. 2 years even still feels a little bit short. That's where I have the conversation to say, because oftentimes the remission after a second transplant is probably about half the time of the first transplant remission. So, and it's a lot to go through with a transplant. So you really want to make sure it's worth your while and weigh it against the other medications that are still available to you that you haven't seen. But wait, there's more. And this is where it gets exciting. So let's move on. So what is BCMA? So I mentioned earlier about CD38, about having this little tag on the myeloma cells that says, hey, yo, I'm over here. I'm the myeloma. Come on over and get it. BCMA is similar. So BCMA is one particular flag that is specifically on myeloma cells and not on many other cells. And so if we had some form of a medication that had a little radar system, if you think about it, that looked for the BCMA, and basically shot its gun at it or stuck to it or inserted chemo into it or said, hey, immune system, I got him. Come on over and attack. There are really important ways that we can take advantage of BCMA. So this has kind of been the darling, if you will, of multiple myeloma in the last several years, trying to figure out how we can exploit this discovery. So here's one way that we can do it. So antibody drug conjugates. Now, there was a drug that was approved by the FDA last year called Blenrep, or belantamab mafodotin. How about that for a mouthful? What it is it's partly on, I think of it as like an arrow. So if you have a bow and arrow and your arrow's target is that BCMA, it sticks to the myeloma cell, right at that BCMA, and it almost like a needle injects a drug into it. So you can see this little star here. The star is what we call a warhead or a payload. It basically is a baby little chemo drug that gets injected into the myeloma cell after the arrow part or the antibody sticks to the BCMA. So it finds the drug, it finds the myeloma cell by sticking to BCMA, and it injects the chemo into it. Awesome. You know, general chemotherapy is designed to just drop an atomic bomb on the entire body and kills all the bad guys and takes all the innocent bystanders with it. But this is exciting because it's really specifically targeting the myeloma cells and sparing all the good guys. So this was an exciting first drug that made it to the finish line that was targeting BCMA to kill myeloma cells. So here it is, belantamab mafodotin. It's the antibody drug conjugate. It was studied in a variety of different doses, finally came down to 2 separate doses, trying to figure out which was the right one that had the most success with the least toxicity. And wouldn't you know, what comes with new drugs is new side effects. So here we are, we myeloma doctors are pretty darn comfortable with your immune system. We're pretty comfortable with your blood levels. We know how to manage neuropathy. We know how to manage diarrhea from your Revlimid. But when it comes to eyes, this is a whole new ballgame. So the biggest problem we've seen with belantamab mafodotin is that it affects the eyes, which is hard. I mean, this is a new thing for us, and people can end up having blurry vision. That happens as the cornea itself can be inflamed, where patients notice that their visual acuity changes, their eyes can get dry, they get blurred vision. So this has been a new side effect that we've had to learn about, because this is an exciting drug, but certainly needs to kind of make sure that this is being watched very carefully. So it actually requires you to see an ophthalmologist before the drug and before every dose, given every 3 weeks. And if there's any signs of eye side effects, then we need to your doctor is going to stay in very close touch with your ophthalmologist so we can make decisions about how to not let that worsen. It is almost always reversible, but it means that the drug has to be held so that we don't let things worsen in the interim. So let's get to the patients who it's not their first time they've relapsed, but they've had, their myeloma come back several different times. They've had 3 different or more combinations of therapy. Now what? So you've made it through all the usual suspects: Revlimid, Pomalyst, Velcade, Kyprolis, daratumumab, cetuximab. It just rolls off the tongue point. So you've had all these drugs, and now what? Well, it's time here, ladies and gentlemen. I feel so honored to do this on the day that it was actually approved. Let's talk about the CARs. So the CARs, or the CAR-Ts we talk about, this is the thing that is finally here. Our lymphoma and leukemia colleagues have really been able to use FDA-approved CAR T cells as a means to treat their patients' cancers. Well, now it's our turn. So let's talk a little bit about what that means. So very, very broadly, how can we use your own immune system to fight your own cancer? Now, similar to what I talked about having BCMA being the target, what this time we're doing with CAR T is we are actually removing your T cells. So T cells are your big immune system fighter cells. They're the guys that are supposed to go out there and seek and destroy. So if I can take your T cells out of you, and the way that happens is very similar to the way you got your stem cells removed, for example. So we hook you up to a machine. It's like you're donating blood. The machine separates out the T cells that we want from the rest of the blood, which goes back into you. Well, the T cells then are sent out, mailed to this special lab somewhere, and they re-engineer them. So when they re-engineer them, they basically construct them in a way to put that new radar system in it to say, all right, here's your immune system fighter cell. Now I'm going to add a new radar system to it. So it says that, hey, when you see BCMA on that myeloma cell, go attack. So now my immune system is taught to look specifically for that BCMA on the myeloma cell. So once the T cells are made at this outside lab, they're mailed back to me. I then give your body a small amount of chemotherapy. I would argue that it's, while 2 medications that we use together, it is tolerated better, the chemotherapy part, than the transplant is. So there are more patients who can do CAR T than potentially patients who undergo auto transplant. There's been studies on CAR T saying that maybe older patients are able to undergo CAR T therapy. There are studies that are coming out to say for patients who are ineligible for a transplant, maybe we should do CAR T up front. So lots coming, but you get chemotherapy as a means to clear out your immune system to make way for the new immune system about to put into you. And then, just similar to getting a blood transfusion from yourself, we base T cells back into you, and then we wait. And what we're waiting for is those T cells to go to work. And that in and of itself has its own complications, I will say, but at least this is how CAR Ts generally work, and we'll get into that a little bit. So here it is. It was just earlier this month that I finally put forward the publication in our very important New England Journal of Medicine. I don't even dare to try and pronounce this. We even, myeloma doctors, just say ida-cel. ida-cel, so you can see it's the first ida and then cell at the end, in relapsed refractory multiple myeloma. It was finally published, and this is usually the first step before the FDA approves it. So once this came out, we knew what was coming next, and today was the day that this drug was approved by the FDA. And just for funsies, they have a really cool, pretty witty name to it. They call it ABCMA. It's spelled ABECMA, just so you know exactly what it is that they're doing, and so that I don't have to say idacaptogene vispaclocil over and over again to you all. So ABCMA has been approved by the FDA, which is the first CAR T that uses your immune system to fight your myeloma by finding that BCMA on the myeloma cell. And so how did we get here? Well, what they did is they looked at various doses. So just like medicine has different strengths, we now have CAR T cells that say, well, if 10 immune system cells are put into me, they can probably do a little bit of a job. But what if I put 100? Could they do a stronger job? Think of an army, right? You can have an army, but if you have a bigger army than your opponent, then probably the more, the better. So what they did first is they looked and said, let me put a little bit of cells in. You can see that they had the numbers at the bottom here, that comment to say they put 150 million cells in or 300 million cells in or whatever it is, and found that more mattered. Patients had more myeloma killed with more cells. So ultimately, remember I said that a lot of drugs were getting approved by the FDA when you have new drugs like pomalidomide, and it works about 20% of the time. Oh my goodness, the bar has moved. Here we are looking at overall response rates from patients who have very few other options at 80%, 80. And so really now we're taking one drug or one new therapy and have said that 80% of people are having it work for them. So this is really changing things, rather, as opposed to the 20 to 30% response rates we saw in a lot of recent drug approvals. This is different. And so there are a lot of CAR Ts out there. It's a kind of been a race to the finish line, as a variety of different companies have made their own CAR T. So they still take your T cells, they still put the BCMA in it, but they say, if I tweak this or tweak that, then mine's different than yours, and maybe mine will work better than yours. And honestly, they're all similar but slightly different, and that seems like it might matter. So while ide-cel was just approved by the FDA, and that was Bluebird, or now Bristol Myers Squibb, and was the company that got their approval. This is Johnson & Johnson. So the CARTITUDE study looked at a similar BCMA CAR T, slightly different, but look at these numbers, 97% of people. And that is a staggering number. We're finally seeing patients who have had no other options respond to something. And it happens fast. You can see the median time to first response is 1 month. So after a month, we're seeing that it already works. And not only that, we're seeing very deep responses. So MRD, I don't touch on much today, but generally, if you think about minimal residual disease, what we are looking for is how much myeloma is left in your system. I can do a bone marrow biopsy and I can do blood tests and see your M spike or see bad guys in your bone marrow. But what if there is so little there that it's only with the fanciest genetic high-tech tools that we can count 1 million cells and find one little smidge of DNA that says, yep, there's still some myeloma here? That is what we do to look for minimal residual disease. And we know that if I can count 1 million cells and find none, that means you are MRD negative. That means that you're going to stay in remission longer than someone else will. And so if that matters, then it's important to recognize that if 96% of patients this is working for, 93% of patients that were evaluated in this study had no disease left when they counted 1 million cells, that is remarkable. So this is really showing us that there is something new and great that is coming up. Now, I see the question from my favorite Tom Tucker that's down there. They're getting approved in terms of progression-free survival times, not overall survival times. So I don't know yet. I don't know in terms of what the overall survival is going to look like overall, but hang in there, stay tuned. The good thing here is that patients are living longer, and it's taking longer for us to estimate that overall survival time because we need to see what happens to all those patients. So here is 1, 2, 3 different BCMA CAR Ts, and this is just 3. These may be the 3 front runners or the ones that are furthest along, but you can see across the board really remarkable response rates. 70, 90, 100% of patients are having success with these medications, and really deep responses, finding that patients are getting to MRD negativity as well. So I go into this a little superficially just to tell you that it's here, but that this is clearly here to stay. And if this is happening with such great results with patients who have had immune systems that have just been beat up, right? All the medicines you got for your myeloma beat up your immune system. And now I'm asking your immune system to fight a war. What if I use those, early cadets when they're brand new soldiers and say, listen, guys, this is how you're gonna, and ladies, this is how you are gonna fight this war. This is, they are armed with more weapons. They are a stronger, less tired immune system that can probably do better work. So maybe eventually what we're going to see is that these are not going to wait until the very last line of therapy as a kind of Hail Mary. This is we're going to see starting to move up sooner and sooner. As Dr. Cole said, maybe it'll replace transplant, to be determined, but lots to come. So here's just a list, the house of CARs. You can see there's a lot of them out there. They all really do quite well. I really just put this up there to show that there's 1, 2, 3, 4, 5, 6 that are listed here, all of which have really nice response rates. One has made it to the finish line first. We'll see what happens with the others. All right, but last but not least, the homecoming queen of ASH 2020 was a whole new class of drugs. So here I just finished telling you, let me take your immune system cells out and I'm going to re-engineer it so that I can put a new reader system in so I can attack the myeloma cell. It's challenging. It's logistically complicated. You have to wait while they make the cells, which sometimes takes way longer time than we have. What if I had a medication that I could just give to you that works similarly? So the homecoming queen is something called a bispecific T-cell engager, a bite, we like to call it. It's like taking a bite out of that myeloma cell. So we talked about, daratumumab, a naked antibody. All it does, there's nothing attached to it. It just sticks to the target, whatever that may be. For daratumumab, CD38. For drug conjugates, we talked about Blenrep or belantamab. That is a drug conjugate where the antibody is attached to a chemo, where then you can have the antibody stick to the BCMA and inject the chemo in. Well, the bispecific, I think of it as a two-headed magnet. It's a magnet that basically says, I'm going to stick to the BCMA and the myeloma on one side, and I'm going to stick to the immune system on the other side and bring those together. So I'm basically bringing the two together so that the immune system can do its job. And so this is it's a two-headed weapon that brings your immune system directly over to your myeloma so that they can say, hey, this is the guy you're supposed to fight. So that's where bispecifics are starting to come to the picture here. So this is what we're trying to do, bring the tumor cell and the immune system together to do the job. So bispecifics, also known as BiTEs. This is just another picture I would say is that BCMA has been our main target, but on the target cell down here at the bottom, you can see that there are a couple other targets or different tags on those myeloma cells that are starting to be evaluated and looked at to see if maybe BCMA doesn't do the job. Well, maybe we can try and find another target or another drug that could potentially do it. So there's logistics here. In order to be able, for cancer centers, in order to be able to offer these, there is a very prolonged certification process that proves that you are able to do this and that you've experienced doing it and you know how to manage the side effects of it. CAR T is a really nice option, but there are some barriers. You have to have all your friendly colleagues that are in the ICU or neurologists or whomever it may be that can help you manage side effects. In order to get the T cells made, we send them off to a company and we have to sit there and wait anxiously for a couple months sometimes. Hopefully that the new one that'll get approved will be down to the 3 to 4 week, but that's still, time and cost. This is expensive. So CAR Ts, I think, are certainly going to play a very important role here, but there are only going to be a select certain number of centers that are going to be able to offer this. So as far as the bispecifics treatment, logistics, these are still only in clinical trials. They are not approved yet by the FDA for the purpose of multiple myeloma. We need to try and figure out how well they work. It's nice that I can prescribe it tomorrow as part of the clinical trial and get you treated. So you don't have to wait. Antibody drug conjugates, I can prescribe that tomorrow as well, but we have to learn these new side effects with the eyes. All of this is expensive. So lots of bispecifics that are out there kind of rushing to the finish line also, all of which that are seeing really remarkable response rates. Just like with the CAR Ts, we're seeing patients who have had very few other remaining options, finding that we're having 50, 60, 80+% response rates in patients and really feeling, pretty satisfied with these responses. A very brief mention on CRS. So CRS means cytokine release syndrome. So if I am telling your immune system to go to work and go to war, the immune system is really good at fighting the bad guys. And the way it does that is it basically recruits its more fighters to the fight. It grows its army. And when it grows its army, they get activated and they start arming themselves with all these tools and they start bringing their guns and knives and lead pipes and ropes to the battle. But when they do that, it can really cause side effects for the patient that can really happen from tip to toe. It can look like patients are having having an infection. They can have big fevers, blood pressure changes. They can have, in really severe cases, can be scary and look like patients are having strokes or seizures, things like that. And so It really takes very experienced people to be able to know how to care for patients who are undergoing CAR T. And bispecifics, because however you're stimulating the immune system, you can see this. And so there are different approaches. We can actually have medications as almost, let's say, antidotes to just calm everything down. If these guys are bringing all their weapons to the battle, we may say we need to get the troops to sit down for a bit. And there are means of doing that. We can use steroids that tells the immune system, the T cells, to just calm down. There's varying degrees or aggressiveness of treatments or antidotes that all depend on the aggressiveness of the reaction. I mentioned this a little bit. There are neurotoxicity. The T cells sometimes can cause neurotoxicity, which, as I mentioned, can look and be scary, but look like strokes, seizures, things like that. They are self-contained. They resolve, but it can be very scary to watch. Logistics, we kind of mentioned a little bit. I'm going to move along because I think I'm getting towards the end, but we talked about how they're manufactured. We talked about the trial that did it, that finally brought us to where we are today with the approval process. And then think about logistics. And what's nice about a CAR T is that we can do one and done. If I can give you one CAR T, I hope that it will provide prolonged remission times where you can be off of treatment, not need Revlimid maintenance, not need some of these drugs. There are logistics that have to happen in order to get us there. But this is an opportunity to potentially to give you a treatment and then take a nice long vacation from it. Does not look curative yet, but to be determined what's going to happen when we start using patients whose immune systems work a little bit better when they've been diagnosed sooner or treated earlier in their disease course. The practical, components of using a BiTE is the same thing as you have to have experienced centers. You have to be prepared for that cytokine release syndrome. But these drugs, you have to keep giving. And so that can be a problem, an Achilles heel, in the sense that you just end up having to give weekly or biweekly infusions, whatever it may be. So it doesn't do the same thing that CAR Ts are, where it's one and done. But the fact that I can prescribe this and give it to you pretty quickly and move along just kind of adds a new weapon to our arsenal. Biggest question, is any of this going to make me feel any better? So, we will figure this out. What we know is that if we compare it to patients who've had kind of our standard treatments. Mammoth was a study that was done that looked at a variety of our different kind of treatments that we're already well familiar with. It looks like patients are being treated with CAR T are potentially living longer than those who are using kind of the usual suspects at this point in their disease course. Same with progression-free survival. I think, our conventional treatments versus what we have now for patients with very advanced disease really looks like this is going to be an important tool in our arsenal. And it matters. People feel better. When they did studies on patients and asked them how they felt while they were going through this, they noted significant improvements in emotional functioning and social functioning and just physically feeling better. And so, yes, you're going through pretty rigorous treatments, but at the ultimate endpoint and what is, I think, most important, the quality of life. And patients found that there was an immediate improvement for those patients who received these treatments. And across the board, really seeing that patients had improvement more so than they had side effects. So while the side effects may be scary, ultimately, this is up to 9 months after the therapy, patients were feeling better across the board. So conclusions. So lots coming, including today, with really impressive response rates, with unprecedented remission periods. Patients are feeling good. They're feeling good and they're getting better. Yet to be determined what the insurance companies think of all of this. And as I mentioned, not curative yet, but my hope is that we're going to see that all of these are moving closer and closer to diagnosis, where we are going to see much more improved outcomes overall. So with that, thank you for listening to me drone on a bit. I hope that was helpful and not overwhelming and not too fast. Kelly, shall I go through some questions?
No, we got to go on to Teresa. We're running a little tight. Do you have to go back around?
I'm good, Kelly. You got me for a little bit.
Okay, let's keep going. Ladies and gentlemen, presentation from the IMF, one of our favorite programs here, the Nurse Leadership Board. Teresa Miceli, once again, all those acronyms, but she's from the Mayo Clinic, Rochester. Now, I broke my pencil earlier, so I'm sharpening it while you guys go on, but please listen to this. It's fantastic. Take it away, Teresa.
All right, Kelly. Thank you so much. I hope everyone can hear me. And yes, I'm Teresa Miceli. I'm a registered nurse at Mayo Clinic in Rochester, and I've spent, Dr. Cole had said he didn't want to say, but I've spent the last 30 years working in the area of blood and marrow transplant. And I'm really excited to be here with Kelly, with the entire team. Truly, one of my favorite things is to participate in these meetings, as well as to facilitate my support group, which is in Rochester. However, it is virtual, so anybody can attend if you so choose. Happy to have you participate. You know, I really want to have a sort of a conversation more about how to be empowered to be your own self-advocate. Provided fabulous information. And I have to tell you, it's a little hard to meet the energy level of Dr. Costello. She was worried about meeting or following Dr. Cole, but I'll tell you, the two of them are just, but when you think about all these treatment options, as Dr. Costello talked about, you know, that it's really confusing for people. And it's not just confusing for you as a patient or caregiver, it's really confusing for the care providers, your healthcare team, because, you know, with the riches that we now have, sequencing therapy can be challenging. And as Dr. Costello nicely outlined, we really have to look at multiple facets. We have to look at what does the most recent data show? Now that CAR T has been approved, where is that going to sit in a person's whole treatment trajectory or journey? What are your preferences and your goals? And what is your healthcare provider's clinical experience and access to some of these therapies? And so with all of that, we come to a treatment decision, and we really want for you to be a part of that treatment decision. And I'm hopeful that I can give you some tools to help you be self-advocating, to feel empowered. We kind of went with a galactic theme here because of 2020 with the mission to Mars 50th anniversary. And so really, Scotty, we need more power. We want you to really be engaged with the decision-making process. So how can you do that? Understanding your treatment options is really key. The education that is needed to stay abreast of all the therapies that are now available and the combinations that can be used. Sources of information like today's session is invaluable. We really want people to be engaged with their support groups, with the IMF's educational offerings, such as the workshops, as well as what's online. Be a part of that decision making. And some of that has to do with having the confidence to come with questions. You don't have to necessarily have all the answers, but you need to be a part of that decision making, to create the dialogue, to really determine what your goals and values and preferences are. When you're newly diagnosed, your immediate goal is, I want to understand, I want to live, and throughout the trajectory of this disease. But we really need to be thinking about quality of life so that when we look at your goals, your priorities, your preferences, we can come to a mutual decision on how to approach treating your myeloma, whether it's newly diagnosed or in a relapsed stage. So when we think about communicating, it's not just your goals and preferences, but it's important to talk about your symptoms, whether it be physical or emotional. All too often, issues such as anxiety and depression are not brought to the table for discussion. And we really need to have conversations because the mind and the body connection is so strong. It's helpful if you can keep a symptom diary. Maybe days after DEX, you're finding that you are hugely down and that's worsening your depression, or while you're on DEX, you're having significant issues with anxiety. It's important to keep that diary so that you can discuss it with your providers. Fatigue is experienced by the majority of patients from prior to being diagnosed throughout the entire trajectory of the disease. And all of these things can have an impact on your quality of life and your willingness to continue therapy. And of course, if you're not on effective therapy or being able to stay on effective therapy, the outcome becomes more dim. And so it's important that we discuss all of these issues whether it be physical symptoms or emotional symptoms that come from the diagnosis, that come from the treatment, so that we can address them to help you stay on therapy longer. Many people really, really struggle with dexamethasone. And so with that in mind, if you are struggling and you're saying, I'm just going to stop it, well, maybe you need to talk about this so that we can consider a dose adjustment rather than a whole discontinuation of that medication. So when you're thinking about communicating with your team and preparing for your next meeting with your provider, it's helpful to write down your questions ahead of time. It's easy as we experience chemo brain, and I always tell my patients that have chemo brain by association that you want to write down the questions when they come to your mind. Different medications as well as your supplements to your next appointment. Be sure to bring with updates in what has been happening in your life, whether it's good, bad, or ugly. It's important that we know what's happening in your life so that we can help you with that decision-making process. And have any of your symptoms changed? Have they gotten better? Have they gotten worse? I have a number of people that have sort of a non-experience with neuropathy until one day it just starts to happen. And you can even send online messaging for many people who have what are the portal to your healthcare provider so that these things can maybe even be addressed before your next visit. So when you're at your appointment, what are the important aspects of that? You want to be able to speak up. You want to have a relationship with your healthcare team that you feel comfortable bringing your questions. Even for people who are worried about having a stupid question, there are no stupid questions. We want to make sure that you are having your concerns and your side effects and your needs being met. But please do make sure that the most important questions are the ones that are being asked first. You may think, and your healthcare provider would like for you to think that you're the only person they're seeing that day, but quite honestly, you know that there's somebody else who has important questions next. So make sure that those questions are being addressed. Understand your plan of care and what your next steps are, your follow-up plan, your next line of therapy. When are you having your next infusion, whether it be a bone strengthener, or daratumumab, or some other therapy. Understand what the next steps are in your plan before you leave. And if you do have questions after you leave, know how you can reach your care team, whether it be through the portal, through phone calls, but make sure that you know how to reach your care team after you leave. It is helpful, especially during pivotal meetings, whether it be at the time of being newly diagnosed, where there's maybe a change in therapy, at a relapse, or some key elements. It can be helpful to have a caregiver be a part of that meeting as another set of ears. Now with COVID-19, that having extra people being present can be challenging due to limitations at healthcare centers, but that doesn't mean they can't be present by phone. And so I'm always very comfortable with people dialing in somebody during our visit, or even recording our visit. So that's something that you can check with your healthcare provider if they're comfortable with the recording that you can listen to again later. Because later, when you navigate home, when you get home, it's going to be important to be able to digest all the information that you've received. And maybe you need to be the connecting link between other healthcare members of your team, whether it be a primary care physician, your pharmacist, your special order pharmacist. Know what changes have been made, take the notes, and if you don't recall, send a portal, get an update, copy off your medical record in the most recent visit. You can review many of those things through the electronic healthcare record. Always feel free to follow up with your healthcare team if there are missing components to the meeting. In the day of COVID, or in our current era, one of the best things that I think have happened are virtual meetings like this, where I can be in Minnesota and be joining you in San Diego, as well as telemedicine. Telemedicine has been amazing, and I've enjoyed many of my telemedicine visits with my patients because they're in the convenience of their own home. I can actually get a little look around and see how they're doing physically and functionally within their household. This is also a possible option for a second opinion. Maybe those of you in California have always wanted to have a second opinion with somebody at Mayo Clinic in Rochester, but you were afraid of the snow. Okay, I'll tell you, there's not a drop of snow to be seen in my neighborhood right now. But this is also something that has become very popular as a second opinion virtual visit. There's a lot of planning that can go with that, and some of that is not too different than what we've already talked about for a face-to-face visit. But maybe you need to be planning your blood work in advance, having it done a couple of days ahead of time so those results are available with your healthcare team, whether it be through Epic or through a fax, or that you can share with them when you're at the meeting virtually. Be understanding of the technology. Not everybody is techno savvy. Know what the setting is that you're going to be in. Like right now, I'm in my quiet office with some mood lighting. My dog is in the backyard, and my cat thankfully hasn't kitty bombed our meeting today. But know what your session, your meeting session is going to be like. Maybe you need to expose a certain part of your body. Wear a piece of clothing that's easier to show whatever skin body part may need to be shown. Know that your Wi-Fi is strong enough. I know that my connection is sometimes disabled during my meetings, and that can be a little bit frustrating. If you have a blood pressure cuff at home, take your vital signs, do your heart rate. Those are things that are easy enough for us to show you how to do. And if you're running into blood pressure issues, we'd like to know that. So by the time we're done with our virtual visit, it's always nice to know what's our next step, whether it be virtual or in person. Every now and then, it's really nice to have an in-person visit. What are the next tests that we're going to be doing? How about medication refills? Is there anything that you need refilled as part of this visit? So it's important to engage with your healthcare team. And I think really important is to understand who all the members are of your crew to make this a successful journey. Are you meeting with your general hem-onc? And as Dr. Costello said, she really recommends that people have a myeloma specialist, whether you see them once a year at pivotal times when changes in therapy need to be addressed. Who are the healthcare team members that you rely on? I have a number of patients that seek me out specifically because we've had a long-term relationship and we want to, connect, and I understand what their needs are. How about subspecialists, whether it be your orthopedist, maybe an infectious disease specialist if you've had some issues with infection. So know who to go to for what concerns. You really want to spend your myeloma specialist and general hem-onc time on your myeloma. You want your primary care provider to be addressing things like hypertension, blood sugar management, thyroid issues. And please don't forget your family and support network. That includes the support group that you may be attending, family, whether it be through Zoom and Skype type meetings. They are an essential part of this group. Central to the care team, of course, is you and your caregiver. And I will say that truly, essentially, is the caregiver within this crew of team to make this a successful journey. For the majority of myeloma care, people are cared for on an outpatient basis. So that responsibility that goes to you as the myeloma survivor and your caregivers can be pretty tremendous, not only taking care of those medications day to day, but contacting that healthcare team and the proper healthcare team member when something new comes up. Myeloma patients need support from many areas, but the caregiver also needs support. And so when we think of formal and informal caregivers, look at who is supporting whom. I encourage people to have multiple informal caregivers, people that you can call upon within your community. I know that we have to be very careful right now with COVID as far as how closely we're exposed, but there's nothing wrong with picking up the phone and having a conversation. Caregiver duties, can be stressful. I want you to be sure as a caregiver, because I know that there are probably 2 people per computer right now for many of these people attending. Caregivers need to be able to help themselves as well as help the myeloma survivor. When you're on an airplane, a year ago now, for myself, they always say, make sure that you put the oxygen mask on yourself before you help somebody else. And that's true as a caregiver. If you're unable to help yourself, you're not going to have the energy to help the person who needs it. And so these next few slides really do pertain to both the caregiver as well as the myeloma survivor. We want to think about ways of adding to a healthy or healthful lifestyle, diet. There are a lot of approaches and ways that we can do this. Are helping to manage stress through mind and body connection, through rest and relaxation, meditation. Activity can be very helpful in helping to manage stress. There are complementary and integrative therapies that can also be helpful, from massage. If you have myeloma bone involvement, you want to be careful about massage and that it's not too deep. But a gentle massage or acupuncture can be very helpful in ways of managing different aspects of pain, like neuropathy. You also want to do general health care screening. Unfortunately, having myeloma doesn't get you an out-of-jail-free card for other health-related issues. And in some ways, it can add to those health needs as far as health screening. So important is to think about the whole mind and body connection, making sure that you're maintaining a healthy body weight, which for many, myself included, COVID-19 has meant COVID-19. And so working back on trying to get to a healthy weight, healthy activity, eating vegetables, fruits, the whole grains, trying to reduce those high-fat proteins and work towards lean proteins like chicken and fish, limiting foods that are higher in fat, higher in sugar, that are going to add to those emotional ups and downs. High sugar diets have these peaks and valleys of energy and emotional experiences that can add to depression and anxiety. Alcohol can do the same, and alcohol can really disrupt your sleeping pattern. And so it's important to keep alcohol at a moderation, or if it's not even needed, eliminate it. Actually, it's never really needed, but there is some research that says that a glass of red wine can be helpful in the flavonoids, I believe it is. And supplements, making sure that you are checking with your healthcare team on what supplements. Dr. Cole mentioned a bit about this earlier in his talk, that there, at least in research at the bench, that there can be some concern about how some of the supplements will interact with your myeloma therapy. And then I think key is really activity. Activity helps in so many ways, from the mental re-strengthening and physical re-strengthening, reducing pain. There are a lot of research studies that have shown that neuropathy and bone pain can be reduced through activity. Of course, you have to keep that in mind with what type of activity, based on if you have any bone-related issues from your myeloma. You also want to be very careful about using the right type of assistive devices if you're having neuropathy or weakness. But core strengthening, working with physical therapy, all of these things can enhance your well-being, enhance your immune system. And so going for a walk is a good idea. I think key to my message here is that knowledge is power. And I'm so thankful to the IMF that the resources that they've made available in multiple forms, whether it be a meeting like this, through the pre-recorded webinars that they have available, and printed materials that they allow you access to free of charge. So I encourage you to reach out for any of these materials, as well as their information or info line is available 9 to 4 Pacific time, and is a wealth of knowledge. And if they by chance don't actually have the answer, which is pretty rare now, they will find the answer for you. So I want to thank you for taking the time to listen to these tips on self-empowerment and self-advocacy for both the myeloma survivor and the caregiver. And I think, Kelly, if there are any questions or if we're running out of time, happy to move on and do the group panel.
Well, the questions have been answered during the session. Are there any additional questions right now? Please type them in a fast sense. 1, 2, 3, 4, 5. There is nothing. Okay, let's pass on. Thanks for doctors for answering the questions. And I want to thank you both for being on here. Of course, Teresa. I think it's really important right now to take a second and look at the workshop video replay. You will be getting that. If you registered, you'll get a note that it's available, and you can go a little slower if you like, as I said earlier, or you can go faster or get to the point where you want to be. Very easy place to go. The next slide, feedback survey. Remember when I asked that earlier, you have to help me out here. It just takes a few seconds. Really, it's not that long. It's going to help future workshops. This is very, very important to me personally and to the IMF. Next slide. And of course, it's one more time to thank our incredible sponsors: Binding Site, Bristol Myers Squibb, GSK, Jensen, Karyopharm, and I can't say it, Oncopeptides. Excuse me, sponsor. I have a hard time saying that. Next slide. And that is it today. Why don't you just look at our little roll here? I have to thank a lot of people that helped us out. Thank you so much again, and I really look forward to seeing you in our future regional community workshops.